Hello, welcome to Pathagonia. Happy holidays, and we're almost to the new year of 2024. Before we begin talking about patterns of GI tract injury, I really recommend you check out Kurt's Notes website if you already haven't. Dr. Schaberg has this excellent page where you have all these notes from literally head to toe, excellent for med students, path residents, and staff alike. It also has quizzes, a little about me section, links, articles, and books. Without further ado, let's talk about GI tract injury patterns from figuratively speaking, head to toe, going from esophagus, and we'll take that journey down to the stomach and to the colon, all the way down to the colon. So esophagus, histologically, you'll get this non-keratinizing stratified squamous mucosa with muscularis mucosae. You can see esophageal ducts. Your submucosal glands kind of dump mucin among other substances into the esophageal duct, which then releases it into the lumen of the esophagus, which lubricates the esophagus. Benign incidental findings include your gastric inlet patch, which is heterotopic gastric mucosa in esophagus, pancreatic heterotopia or metaplasia, and glycogenic acanthosis, which is epithelial hyperplasia with abundant and large superficial glycogenated cells, clinically appears white. And one of my co-residents gave a talk about syndromic GI entities, and glycogenic acanthosis is associated, can be seen in those with Cowden's syndrome. And you can get your tricholamomas, glycogenic acanthosis, endometrial cancers, and follicular thyroid cancers. And then going back to the histology of your muscularis mucosae, this is why knowing your histology is so important, because in the esophagus, your muscularis mucosae can be reduplicated. So that's pertinent, especially if you have cancer and you think it blows past the muscularis mucosae into the submucosae. You just want to really make sure that it is actually past the submucosae and not just only past the first layer of your reduplicated muscularis mucosae, because that changes staging. Acute esophagitis is when you see intraepithelial newts with erosion and ulceration. What's the difference between erosion and ulceration? Erosion is when there's partial destruction of your mucosa. Ulceration is this full thickness destruction of the mucosa all the way down to your submucosa. So patterns, when you see intraepithelial newts patterns, you want to think about GERD. This is often scattered eos, usually less than 15 per high power field, with intracellular edema, basal cell hyperplasia, and your elongation of the vascular papillae, as you can see here. It would be elongated. It's worse distally near the GEJ because it's near the stomach, and that's where there can be acid backflow. Infections include, you want to think about Candida, look for their hyphae, get your PASD GMS if you're unsure. In the epithelium, look for herpes effect. Look for that 3 M's, molding, margination, multinucleation. And for CMV, look for the mesenchymal cells, look for these giant inclusions. Medications include pill esophagitis, look for crystals, resins, and pill fragments. And if you're unsure but you have a high suspicion, make sure to polarize. The pattern of eosinophilic esophagitis, where you have increased intraepithelial eos, as you can see here. You want to think about GERD, as we mentioned. In addition to what was mentioned just prior, you can get these intraepithelial T lymphocytes, which are, when you see like these squiggly cells, those are actually T lymphocytes kind of making its way in between the cells of the epidermis. And then you want to think about EOE when there's typically it's greater than 20 EOs per high power field. You'll often see eosinophilic microabscesses with degranulation. In our institution, we define eosinophilic microabscesses when there's 4 or more EOs all within one pocket of space in the epithelium. It'll be often diffuse or worse proximally and is associated with your atopic triad, allergies, asthma, eczema. Does step 1 ring a bell to anyone? It does to me. Well, it can present with dysphagia, chest pain, food impaction, And endoscopically, they suspect EOE, especially when they see this trachealization or felinization, where it kind of looks like the trachea. They can also have like this tug sign, where they have to use a lot of force, more force to get the sample out, because histologically, those who have bad EOE have significant lamina propria fibrosis. And then you can get allergies. Other entities for that can cause eosinophilic esophagitis include allergies, systemic autoimmune disorders, and medication reaction. Your perikeratosis pattern. What is perikeratosis? First of all, this is when your superficial squamous cells, which should not have any nucleus, has retained nucleus. You can see this in GERD. You can see this in Candida esophagitis. Look for your fungal hyphae at the surface, particularly in immunosuppressed individuals. Your epithelium, the superficial epithelium, will kind of look like shredded wheat for some cases of Candida esophagitis. Budding yeasts are not good enough. Esophagitis dessicans superficialis, or sloughing esophagitis. You'll have histologically a superficial mummified layer with gross nuclei with variable necrosis but minimal inflammation. Clinically, it can be quite dramatic with extensive peeling and fissuring. Going back histologically, sometimes you can see just clumps of bacteria, and it has been associated with thermal injury, medications, and some autoimmune conditions. And then your last differential for perikeratosis pattern include esophageal leukoplakia or epidermoid metaplasia. It looks like skin with keratinization and a granular layer, and it's associated with motility disorders and oral leukoplakia, and it's a possible increased risk of dysplasia or squamous cell carcinoma. Your lymphocytic pattern is when you have these intraepithelial lymphocytes. You can see this in GERD. You can see this in lichen planus. Usually we associate this with skin, but it can also happen in the mucosa, where you'll have lichenoid, basically means like band-like infiltrate at junction between the epithelium and submucosa. You'll see these dyskeratotic keratinocytes, which are pink, they're condensed, they're kind of clefted out amongst your other cells in the epidermis, and they're called SAVAT bodies. And it's associated with cutaneous lichen planus, certain medications, and viral infections. And it's often seen in older women, and there's a risk of dysplasia and can lead to increased chance of squamous cell carcinoma from that chronic inflammation. Graft-versus-host disease, especially for those who had a bone marrow transplant. This is when your donor T lymphocytes attack host tissue, and it typically presents with rash, diarrhea, elevated LFTs. You'll get intraepithelial lymphocytes with your SAVAT bodies and scattered apoptotic bodies. And you want to make sure your CMV IHC is negative. And again, this can happen when you get an organ transplant, not necessarily just your bone marrow transplant. Crohn's disease, look in the lamina propria for granulomas. Remember, it's a rectal sparing, but generally rectal sparing, but it can happen anywhere along the GI tract. Contact mucositis. It may be a generalized response to mucosal injury, such as like an allergy to a medication or food. And then other entities for lymphocytic gastritis include CVID, celiac disease, dysmotility. So on to stomach, but before, just a quick recap. Benign findings in the esophagus include your gastric inlet patch, pancreatic heterotopia metaplasia, glycogenic acanthosis. Remember, you can get reduplication of the muscularis mucosae. Acute esophagitis, think GERD, infections like Candida, CMV, or HSV, and medications. Eosinophilic esophagitis, think about allergies, systemic autoimmune disorders or medication reaction, EOE, or GERD. Perikeratosis pattern, think about GERD, Candida esophagitis, esophagitis dessicans superficialis, as well as epidermoid metaplasia. And lymphocytic pattern, GERD, lichen planus, graft-versus-host disease, Crohn's disease, contact mucositis, and other entities like CVID, celiac, dysmotility. Okay, stomach. Histologically, around 90% of the stomach is made up of oxyntic mucosa. These are present in the body and fundus, and you'll have these pink parietal cells make acid and intrinsic factor B12, as well as purple chief cells make pepsinogen. At our institution, we define histologically that it's oxyntic mucosa when we see the chief cells. And then antral mucosa is present in the distal antrum and cardia. And the gastrin-secreting G cells are found only in antrum. This is especially helpful when you're seeing an oxyntic section of the stomach that looks like antrum, and you get your G stain and it's negative. That increases your suspicion that this is AMAG. And we'll talk about that in the coming slide. And antral mucosa is usually extremely few inflammatory cells, except at the gastric cardia, which commonly has some chronic inflammation. So reactive chemical gastritis, gastropathy, you'll have this foveolar hyperplasia where you'll get this corkscrewing, you'll have mucin depletion, edema, minimal inflammation, and extension of the splaying of the smooth muscle bands of your muscularis mucosae between the glands. And it's often caused by chemical irritation, such as bile reflux, medications like NSAIDs or alcohol. Other causes of reactive gastritis include portal hypertensive gastropathy. You'll have the above findings plus dilated vessels in the lamina propria. It's seen in patients with portal hypertension, and endoscopically it looks like snake skin. GAVE, or gastric antrovascular ectasia. This is seen in the antrum, as you can tell by its name. And endoscopically, it looks like a watermelon, and you'll have the above findings plus the fibrin thrombi present in the lamina propria capillaries. Acute gastritis pattern is when you have intraepithelial newts, often with erosion or ulceration. You want to think about Helicobacter pylori. This is acute gastritis with characteristic superficial lymphoplasmacytic inflammation and prominent lymphoid aggregates. It's most common in the antrum, and you want to look hard in the pits and consider getting H. pylori IHC. Also, H. pylori likes to be in the mucin, kind of the schmutz, so also look in the schmutz in the pits. And there is a risk of MALT lymphoma, which is a subtype of marginal zone lymphoma, CD5, CD10 negative. And you can have increased risk of dysplasia or carcinoma. Helicobacter heilmannii, there's less acute inflammation. It's more common in kids. And compared to the H. pylori, which looks like seagulls on H&E, these organisms are longer, they're more tightly spiraled like your spirochetes, and less numerous. Medications, especially NSAIDs, which can cause ischemic or reactive changes, and focally enhanced gastritis, which is focally injured glands surrounded by inflammation. It's associated in kids with IBD, such as Crohn's disease, as well as CMV. Look for those large inclusions. Chronic gastritis is when you have chronic inflammation in the lamina propria. It's pushing up against the glands in the mucosa. You want to think about H. pylori, especially if your chronic gastritis has germinal centers. Autoimmune metaplastic atrophic gastritis, or AMAG. This is when your autoantibodies destroy your parietal cells. Or oxyntic mucosa. The parietal cells are those pink cells that secrete acid and intrinsic factor. And because there's no intrinsic factor, you're going to have a vitamin B12 deficiency, and that's going to lead to pernicious anemia. And if you do a peripheral smear on these patients, you should see a macrocytic anemia, just a tie-in heme path. In the body, you'll see predominantly loss of oxyntic mucosa because your parietal cells are getting destroyed. You'll have this deep chronic inflammation that's going to lead to intestinal and pyloric metaplasia and ECL or enterochromaffin-like cell hyperplasia. And that can lead to an increased risk of neuroendocrine tumors, especially type 1, or defined by type 1. I think it's because it's in the setting of AMAG is type 1. And so your body looks antralized, and how do you know if that antralized body or the actual antrum, how do you know which is which? You can order a gastrin stain, and that can help confirm whether it's from the body, negative, or antrum positive because only the G cells are in the antrum. And why is there ECL cell hyperplasia? Well, it's connected with the gastrin. Because the G cells sense that the stomach is not making acid, and that's because your parietal cells, which makes the acid, are getting destroyed, your G cells are like, I need to secrete more gastrin to tell the parietal cells to secrete acid. So it keeps on producing gastrin. Well, the thing is, gastrin also tells the ECL cells to secrete histamine. And gastrin stimulates ECL cells to undergo hyperplasia, especially when you have high amounts of gastrin. And that's why you have that ECL cell hyperplasia. You can get chronic gastritis from medications, especially NSAIDs, and other entities include CVID and celiac disease. Lymphocytic gastritis, when you have intraepithelial lymphocytes, as you can see here. You can see this in H. pylori, celiac disease, medications like ticlopidine and olmesartan, HIV, other immune-mediated disorders like CVID, Crohn's, lymphocytic colitis, and lymphoma. Collagenous gastritis, this is when you have this increased subepithelial collagen band with intraepithelial lymphocytes. And if you're unsure, you can get a trichrome to help highlight that. I like to think of your subepithelial collagen as a one-way road. And if you have collagenous gastritis, it's not a one-way road. It's a multi-lane I-34 kind of intersection, a highway. And so I like to think. You'll have this collagenous colitis, enteritis, celiac disease, medications such as olmesartan, H. pylori, as well as other immune-mediated disorders that can lead to this collagenous gastritis pattern. Eosinophilic gastritis. What exactly is the cutoff? There is no strict cutoff, but greater than 30 per high power field is likely too many, and any in the epithelium, submucosa, like you can see here, it's in the epithelium, submucosa or muscle is abnormal. And some differentials include your eosinophilic gastritis, gastroenteritis. This is a diagnosis of exclusion. It can be associated with eosinophil-rich inflammation in other organs like the colon, the small bowel, esophagus, H. pylori, parasites, connective tissue disease, vasculitis, food allergies, medications, and inflammatory bowel disease, particularly Crohn's. Oxyntic gland hyperplasia. You'll see these dilated oxyntic glands with hypertrophic parietal cells with snouts, as you can see here. It kind of reminds me of like apocrine metaplasia of the breast, so to speak. But anyway, going back to the stomach, oxyntic gland hyperplasia, you can see these in your single sporadic polyp or in the fundus gland polyp. It's associated with PPI use. Mechanistically, it's because of increased gastrin levels through feedback causing parietal cell hypertrophy. It's an extremely low risk of dysplasia or progression. But if there is a dysplastic fundus gland polyp or there's innumerable, you want to consider syndromes like FAP, which is 5q21. It can become dysplastic, but still a low rate of progression to carcinoma. You want to be more concerned about the higher risk of colon cancer for FAP. MUT-YH associated polyposis and your Zollinger-Ellison syndrome, where you'll have a functional neuroendocrine tumor like a gastrinoma, usually in the small bowel, that causes increased acid secretion in ulcers and associated with MEN1. Oh, excuse me, just taking a drink. Foveolar hyperplasia. You'll get these corkscrew glands, mucin depletion, edema. Single sporadic polyp is a hyperplastic polyp, and it's associated with background inflammatory injury, and it's extremely low risk of dysplasia progression. And if you see innumerable or dysplastic, consider Menetrier's disease, where you'll have this foveolar hyperplasia all throughout the whole stomach and protein-losing enteropathy. P10 syndrome, like Cowden's, Cronkite Candida syndrome, where you can also get your juvenile polyps in the colon and the small bowel, juvenile polyposis, and Peutz-Jeghers syndrome. Whew, we made it. So before we begin small bowel, think about gastritis patterns or stomach patterns. You have your oxyntic, antral. Oxyntic is parietal chief. Antral is where H. pylori and your G cells are. Reactive gastritis, chemical irritation, portal hypertensive gastropathy. You'll see dilated vessels in the lamina propria, as well as GAVE, which is dilated vessels with fibrin thrombi and in the antrum. Acute gastritis, you can see this in H. pylori, H. heilmannii, medications, focally enhanced gastritis, CMV. Chronic gastritis, H. pylori, especially if there's a germinal center, AMAG. Gastrin stain tells you whether it's actually antrum or antralized oxyntic mucosa. You'll see, increase your suspicion, especially if you see intestinal or pyloric metaplasia and ECL cell hyperplasia. You have increased risk of pernicious anemia and neuroendocrine tumor type 1. Medications and CVID celiacs. Lymphocytic gastritis, where you have intraepithelial lymphocytes. See this in H. pylori, celiac disease, meds like ticlopidine, olmesartan, HIV, other immune-mediated disorders, lymphoma. Collagenous gastritis, you have your subepithelial highway. You can see this in collagenous colitis, celiac disease, meds, helicobacter, other immune-mediated disorders. Eosinophilic gastritis, no exact cutoff, but greater than 30 high-power field, and any in the epithelium, submucosa, or muscle is abnormal. I see this in eosinophilic gastritis, diagnosis of exclusion, H. pylori, parasites, connective tissue disease, vasculitis, food allergies, meds, IBD. Oxyntic gland hyperplasia, you'll get hypertrophic parietal cells with snouts. Just one, funded gland polyp due to PPI use, possibly. Numerable or dysplastic, think about FAP, MUT-YH associated polyposis, Zollinger-Ellison syndrome. Foveolar hyperplasia, one is hyperplastic. If you see multiple or dysplastic, think about Menetrier-Ayres disease, P10 syndromes like Caldens, Cronkite Candida, juvenile polyposis, and Peutz-Jeghers. Small bowel, quick checklist. When you see small bowel, think about in your head, villi. Is it long and skinny, or is it blunted with celiacs? Goblet cells can go away with autoimmune enteropathy. Intraepithelial lymphocytes increased in celiacs, especially in the tips of the villi. Plasma cells go away with CVID. Critters, look for Giardia. Vessels, okay. If not, if there's thickening, think about amyloid, or if there's inflammation, vasculitis. And endocrine cells, it goes away with endocrine dysgenesis. Okay, acute duodenitis. This is where you have newts in the duodenal epithelium, as you can see here. You can also see gastric foveolar metaplasia, as you can see here, for peptic duodenitis, I meant, and chronic inflammation. It's associated with excess gastric acid and or H. pylori, so peptic duodenitis. Another one is infection, most commonly helicobacter, and can lead to ulcers and peptic ulcer disease, but sometimes adenovirus, CMV, or other. Medication, your NSAIDs, just like location in real estate. And then IBD, particularly Crohn's. Acute ileitis, this is when you have neutrophils in your ileal epithelium. Medications, NSAIDs, infection, including common stool pathogen, bacterial and viral, and IBD. Crohn's disease is most likely to impact the terminal ileum, so look for your granulomas and signs of chronicity, such as architectural changes and pyloric gland metaplasia. In ulcerative colitis, there is typically inflammation in the nearby cecum. That's thought to be due to backwash. Eosinophilic gastroenteritis, you'll have increased EOs. Greater than 60 per high power field in the small bowel is likely too many, and any in the epithelium, submucosa, or muscle is abnormal. Eosinophilic gastroenteritis, again, it's a diagnosis of exclusion like the stomach, can be associated with eosinophil-rich inflammation in other organs, and the layer of the bowel where you see the EOs involved determines symptoms. If it's in the mucosa, you'll get diarrhea, malabsorption, muscle, ileus, and serosa, ileus, and ascites. Other entities that can cause eosinophilic gastroenteritis include parasites, connective tissue diseases, vasculitis, food allergies, medications, and IBD, such as Crohn's. Chronic injury in the small bowel, this is when you have architectural distortion. That includes crypt branching, crypt dropout, and pyloric gland metaplasia, often with villus blunting and a basal lymphoplasmacytosis. And it often starts to look like colon with inflammatory bowel disease. So there's a lot of findings, or a lot of things that can cause this chronic injury, including IBD, where you'll have not only chronic but active inflammation as well, with cryptitis, crypt abscesses, particularly Crohn's in the terminal ileum. Look for your granulomas, transmural inflammation in the resections. Diaphragm disease due to NSAIDs, and some mild manifestation is erosions with associated acute inflammation. Severe is multiple episodes can cause scarring and stenosis. Usually less chronic inflammation than Crohn's. Medications include your Celcept or mycophenolate, which is an immunosuppressant usually after solid organ transplantation, and it can cause epithelial crypt damage with increased apoptosis and causes diarrhea. Ischemia, you can get severe pain, coagulative necrosis, crypt withering, lamina propria hyalinization, hemorrhage, erosion, and reperfusion brings acute inflammation. Radiation, it's most sensitive to damage. You'll get endothelial injury, lead to edema, fibrin, ischemic changes with enlarged basal nuclei. Graft versus host disease. So you can get, this is when your donor T lymphocytes attack the host bowel, and you'll see apoptotic bodies first in the crypt, and then severe damage shows crypt abscess, crypt distortion, and epithelial destruction. And then there's graft rejection, where your host T lymphocytes attack the donor bowel, and it's similar to graft versus host disease, where you'll have inflammation, mostly lymphs, with crypt destruction and apoptosis. There's the Lerner system for grading graft versus host disease. Grade 1 is just isolated apoptotic bodies. Grade 2 is loss or damage of isolated crypts with or without crypt abscesses. Grade 3 is loss of 2 or more contiguous crypts. And grade 4 is extensive crypt loss with epithelial destruction. IPAA, which is ileopouch anal anastomosis. These are given to patients with ulcerative colitis or familial adenomatous polyposis syndrome. Usually not given to Crohn's patients, but this can be, chronic architectural changes can be found with IPAA. Pouchitis is acute and chronic inflammation of ileal reservoir, as we can see here. There's an unclear etiology, but often treated with antibiotics and probiotics. If refractory, you want to consider Crohn's. And then cuffitis, which you can see here. This is chronic active inflammation of the rectal cuff, attributed often to residual or recurrent ulcerative colitis. Malabsorption is when you have villus atrophy with increased intraepithelial lymphocytes. Causes diarrhea clinically, often with weight loss, and you can see this in celiac disease or gluten-sensitive enteropathy. The gluten exposure triggers inflammation, primarily in the duodenum. Serologically, you'll have positivity for anti-gliadin, tissue transglutaminase, and anti-endomysial. It's associated with haplotypes HLA-DQ2 or DQ8, And absence of both of these essentially excludes your diagnosis. And number of intraepithelial lymphocytes typically are greater than 20 per 100 enterocytes, and there's a crescendo, there's a lot at the tip of your villi. Malabsorption can be seen in other protein sensitivities like cow milk, soy, eggs, and you'll often have increased eos and mucosa. Peptic duodenitis, which we mentioned, medications, your NSAIDs and olmesartan. Small bowel bacterial overgrowth, which is from excess anaerobic bacteria, often caused by decreased acid and dysmotility, and it digests bile and carbohydrates and leads to variable local damage and bloating. Common variable immunodeficiency, CVID, you'll have impaired B cell differentiation, and usually your plasma cells are absent, and you'll have low serum Igs and recurrent infections. One thing we see for CVID is when you have a GERD infection, you always want to look in the lamina propria for plasma cells, because if you don't have plasma cells, then you want to think about CVID. Tropical sprue. This is unknown etiology, but likely thought to be infectious, especially after travel to Africa, Asia, or South America, and you must exclude other infections. And then autoimmune enteropathy, where you have gut autoantibodies, and that'll lead to often absent goblet or Panna cells, and it's most common in infants, and you can see a similar pattern associated with thymoma. Again, Panna cells are generally in the right colon and the small bowel, just an FYI. It's only when it's in the left colon or the distal portion of the transverse colon that you want to think of chronic damage and IBD. Foamy macrophages in the mucosa, you want to think about your Mycobacterium avium intracellulare, your Whipple's disease, and non-specific macrophages. So your MAC, or Mycobacterium avium intracellulare, and Whipple disease, they're both PAS positive. So how do you tell the difference? Well, your MAI is AFB positive. That's why you want to get that fight stain. And it's generally seen in immunocompromised AIDS defining opportunistic infection. Whipple disease is also PASD positive, and then it causes an infection often inflicting adult white men and leads to arthralgias, weight loss, diarrhea, and you want to treat with antibiotics. Dilated lacteals, where you have engorged dilated lymphatics, as you can see here. You want to think about primary lymphangiectasia. It's poorly understood. It was thought to be dilated lymphatics, and that leads to lymph albumin leakage into gut, and you'll get diarrhea and protein losing enteropathy. Secondary lymphangiectasia can be due to obstruction, tumor, adhesion, stricture, prior surgery. Whew. All right, we're almost at the end of the journey. All right, just to recap, small intestines, villi not long and skinny, think about celiacs. No goblet cells, think about autoimmune enteropathy. Intraepithelial lymphocytes, think about early celiacs. Plasma cells not there, think about CVID. Critters, falling leaves, think about Giardia. Vessels look thickened, inflamed, think about amyloid, vasculitis. No endocrine cells, endocrine dysgenesis. Acute duodenitis, newts in the duodenal epithelium, peptic duodenitis. You can see gastric foveolar metaplasia. Infection like Helicobacter, adenovirus, CMV, medications, NSAIDs, IBD, particularly Crohn's. Acute ileitis, newts in the ileum, medications, infection, IBD. Eosinophilic gastroenteritis, greater than 60 high power field is too many, any in the epithelium, submucosa, or muscle, abnormal. Eosinophilic gastroenteritis, diagnosis of exclusion. Parasites, connective tissue disease, vasculitis, food allergies, medications, IBD. Chronic injury, when you have crypt branching, dropout, pyloric gland metaplasia, villus blunting, basal lymphoplasmacytosis, looks like colon with IBD. Think about IBD, diaphragm disease due to NSAIDs, less chronic inflammation usually than Crohn's. Medications such as mycophenolate, look for those increased apoptosis, ischemia, coagulative necrosis, crypt withering, lamina propria hyalinization and hemorrhage, radiation, endothelial injury, look for ischemic changes with enlarged bizarre nuclei, graft-versus-host disease, you'll see apoptotic bodies in crypts. You can see, spectrum with the learning system for grading GVHD, graft rejection, ileopouch anal anastomosis findings, pouchitis, and cavitis. Malabsorption, think about celiacs, other protein sensitivities like milk, soy, eggs, peptic duodenitis, medications, olmesartan and NSAIDs, small bowel bacterial overgrowth, CVID, tropical sprue, autoimmune enteropathy. You'll have absent goblet or Panna cells, and common in infants. Foamy macrophages, your Mycobacterium avium intracellulare and Whipple disease. Both have PASD positivity, but Mycobacterium avium intracellulare has positive AFB fight. Non-specific macrophages is your other differential. Dilated lacteal, think primary, secondary. Primary, we don't really know the reason why, but it can lead to a protein-losing enteropathy. Secondary can be due to obstruction, tumor, adhesion, stricture, poor surgery. Put in your comments, for your diagnostic comments, like this can be secondary lymphangiectasia, and put in your differential or the possible causes. Colon, your test tubes on a rack. Especially when you get that not from a bird's eye view cross section, but just the side cross section. Again, crypts should be oriented parallel to one another, perpendicular to the surface, resting on the muscularis mucosae, as you can see here. Regional variation: right colon, more lymphocytes, Paneth cells normal, fewer goblet cells. Left colon, less lymphocytes, Paneth cells abnormal, more goblet cells. Some architectural distortion and mucophages in the rectum is considered normal. Okay, what if you see focal active colitis, meaning you get these rare neutrophils in the crypt epithelium? NSAIDs, such as and other medications. Acute self-limited colitis resolves in less than 4 weeks, usually infectious, like your Campylobacter, Salmonella, Shigella, Yersinia, with abrupt onset and coinciding fever. Bowel preparation artifact, ischemic colitis, and IBD. Acute colitis. This is when you have extensive cryptitis and crypt abscesses, where you have your newts within the lumen without features of chronicity. Think about infection, usually acute bacterial or viral, like CMV, Salmonella, Shigella, Campylobacter. Get your PCR studies to rule this out, and often food contamination, fecal oral. You can see maybe pseudomembranes, especially with C. difficile. Medications, NSAIDs. When is it not NSAIDs? I'm just joking, because it really is NSAIDs in GI medication-induced damage. Resins, including K-axylate and sevelamer and ipilimumab. IBD usually has features of chronicity, so it would have to be emerging, meaning like very recent in timing or partially treated. Okay, chronic active colitis. This is active colitis with features of chronicity, such as architectural distortion, such as crypt branching, loss, shortening, your basal lymphoplasmacytosis, and Paneth cell or pyloric metaplasia, especially if it's in the distal half of the transverse colon and the left colon. IBD, you'll see this in IBD. On a mucosal colonic biopsy, it can be impossible to distinguish Crohn's from ulcerative colitis, and you got to rely on clinical and endoscopic impression. But look for your granulomas and dysplasia. Don't be confused, however, for mucin granulomas, which can be seen not in the setting of IBD. And before we go on, look at this architectural change. Think of these tubes being melted. And then chronic active colitis can be seen in infection. Always rule out CMV in refractory IBD. Diverticular disease, such as SCAD or segmental colitis associated with diverticulosis, is most common in older patients in your sigmoid colon. It can mimic IBD with diverticulitis. Diversion-associated colitis and bowel diverted from fecal stream. This causes short-chain fatty acid deficiency. And you can see florid lymphoid hyperplasia with prominent germinal centers. STD proctocolitis in the setting of sexually transmitted diseases like syphilis, lymphogranuloma venereum, chlamydia. Often tons of plasma cells, and considered particularly with primarily rectal disease. Cord colitis syndrome, and this is after umbilical cord transplantation, often see granulomas. And medications, NSAIDs, ipilimumab, and resins. Ischemic colitis, where you get the superficial epithelial damage, erosion, crypt withering, lamina propria hyalinization, and hemorrhage. You can see occasional pseudomembranes and acute inflammation with reperfusion. This can be seen in ischemia due to poor perfusion, especially in the common watershed areas, which is the splenic flexure, rectal sigmoid, and ileocecal regions. In older patients with vascular occlusion or low flow states. Infection, E. coli 0157H7 EHEC, endothelial damage from toxin, Fibrin thrombi often seen associated with hemolytic uremic syndrome, anemia, low platelets, renal failure. C. difficile, where you'll see pseudomembranes, less hyalinization, and crypt withering. Medications can see in NSAIDs, also resins like K-oxalate, sevelamer, and ipilimumab. Eosinophilic colitis, you'll have increased EOs. Again, no strict cutoff, but greater than 60 high power field is likely too many, and any in the epithelium, submucosa, or muscle is abnormal. You can see eosinophilic colitis, gastroenteritis. It's a diagnosis of exclusion. It can be associated with eosinophil-rich inflammation in other organs. Parasites, connective tissue disease, vasculitis, food allergies, medication, systemic mastocytosis, and IBD, particularly Crohn's. Lymphocytic colitis, you'll have increased intraepithelial lymphocytes. You can see this pattern in lymphocytic colitis. Greater than 20 lymphs per 100 epithelial cells is increased, and classically in older women you'll have watery diarrhea, and endoscopic findings will be normal. Collagenous colitis, think about that I-35 highway in the subepithelial collagen layer. It's not a single road, it's a highway. And you'll have not only increased subepithelial collagen layer, but it'll trap inflammatory cells, vessels, and fibroblasts. And I believe that's your key, because sometimes you can get a tangential that looks like thickened subepithelial collagen, but you really want to see that entrapped inflammatory cells and vessels. Medications, including NSAIDs, olmesartan, SSRIs, and viral infections. Granulomatous colitis. So granulomas, as you can see here, this collection of histiocytes. You want to rule out infection with your FITE and GMS PASD. You can see this in Crohn's. It'll be loose, non-necrotizing, seen in less than half of cases, however. In ulcerative colitis, you can see granulomatous reaction to crypt rupture. You're like mucin granulomas. Infections, especially if necrotizing, rule out fungi and mycobacteria, and look out for parasites, schistosomiasis. Other entities for granulomatous colitis include nonspecific mucosal injury, medications, sarcoidosis, cord colitis syndrome, diverticular disease, CVID, and chronic granulomatous disease. Apoptotic colitis, this is when you have increased apoptosis in crypt epithelium. Think graft versus host disease, where your donor T lymphocytes attack the host bowel. Remember that Lerner classification in terms of grading graft versus host disease, because you can see just apoptotic bodies, but severe stages, you can see crypt abscess, crypt distortion, and epithelial destruction. Medication effect. Classic cause is mycophenolate, which has a similar appearance to graft versus host disease, but with more EOs in the lamina propria. Okay, before we begin with pigments and inorganic materials, let's talk about rehash on colon. Right colon, more lymphocytes, panocells normal, fewer goblet cells. Left colon, panocells abnormal, less lymphocytes, more goblet cells. Focal active colitis, meds, acute self-limited colitis, bowel prep artifact, ischemic colitis, and IBD. Acute colitis without features of chronicity, infection, medications, IBD. Chronic active colitis, IBD, infection, diverticular disease, diversion-associated colitis, STD proctocolitis with a lot of plasma cells, cord colitis syndrome, meds. Ischemic colitis, ischemia, infection with your E. coli 0157H7 EHEC, C. difficile, meds like NSAIDs, resins, ipilimumab. Eosinophilic colitis, diagnosis of exclusion, parasites, connective tissue disease, vasculitis, food allergies, medication, systemic mastocytosis, and IBD. Lymphocytic colitis. You see this in lymphocytic colitis, collagenous colitis, which both make up microscopic colitis because it's normal findings on endoscopy. Medications and viral infections. Granulomatous colitis, Crohn's, infection, nonspecific mucosal injury, medication, sarcoid, cord colitis syndrome, diverticular disease, and CVID, and chronic granulomatous disease. Apoptotic colitis, graft versus host disease, and medication effects, specifically or especially mycophenolate. All right, pigments and inorganic material. All right, we have traversed the realm of the GI tract from esophagus to colon. Now we talk about just pigments and inorganic material. Iron appears brown and granular on H&E, blue on iron stain. There are different patterns. Deposition in the lamina propria macrophages suggests prior mucosal microhemorrhages. Coarse crystals at the surface suggest iron pill, and subtle uniform deposition in the deep glands suggests iron overload. Resins. K-oxalate, used to treat hyperkalemia and renal failures, causes ischemic and ulcerative changes linked to fatalities, so urgent diagnosis. It'll be purple on H&E with this narrow fish scale pattern. Man, I'm getting hungry. How about yourself? We're almost there. Cevimeter, you'll have this bright pink to rusty yellow on H&E with irregular fish scale pattern, and used to treat hyperphosphatemia and renal failure and associated with mucosal injury. Bile acid sequestrants like cholestyramine, it binds bile acids and lowers cholesterol and not associated with injury, but if you do see it, it'll be bright pink orange on H&E with a smooth, glassy texture. Lifting agent, this appears homogeneous pink, often with a giant cell response. When fresh, more mucin-like. This is synthetic material injected during EMR, ESD. May resemble amyloidosis, but the Congo red will be negative, or pulse granuloma. Common names include O-rise or Elavue, Crospovidone, which is a coral-shaped, it's got a pink center with a purple coat, and incorporated into many medicines. It's biologically inert, and it's an incidental finding and non-birefringent. Microcystilline cellulose. It appears transparent on H&E. It is birefringent and often rod-shaped, and incorporated into many medicines is biologically inert incidental finding. Calcium appears dark purple and often cracked on H&E. It's black on von Casa. It can be metastatic in normal tissue due to high serum calcium levels or dystrophic, and damaged tissues due to injury or idiopathic. Yttrium labeled microspheres. This appears as dark, opaque, perfect circles. I call these the UFOs of the colon, the GI tract. It's given by interventional radiology as internal radiation therapy for hepatic malignancies. And you often also see radiation injury with bizarre stromal cells. Melanosis, you'll have this coarse brownish black pigment in the cytoplasm of macrophages, and it consists of deposited lipofuscin, the senior freckles of cells. And it's classically associated with laxative use, but can be seen in any disorder with increased epithelial cell turnover, including constipation. Tattoo, very black coarse granules in macrophages, often with a foreign body giant cell reaction. It's used to mark lesions endoscopically for later identification. Muciphages, macrophages eating mucin in the lamina propria, presumably cleaning up after epithelial injury and turnover, very common, especially in the rectum. And then air, pseudolipomatosis, where you'll have empty spaces irregular in size without a foreign body reaction. It's attributed to insufflation artifact and no associated nuclei, so it's not fat. Pneumatosis cystoides intestinalis is empty space with a foreign body reaction, which means it happened in vivo, often iatrogenic or infectious cause. All right, well, thank you so much for accompanying me on this journey of patterns of GI tract injury using Kurt's notes. Just a final recap from head to toe, figuratively speaking, and then let's go on to eat some fish. And I'm just joking because we talked about the K-oxalate fish scales. But esophagus, remember you can get reduplication of the muscularis mucosae. You can get your gastric inlet patch, which is heterotopic gastric mucosa and esophagus, pancreatic heterotopia metaplasia, glycogenic acanthosis, acute esophagitis, where you have intraepithelial newts with erosion, which is partial destruction of the mucosa, or ulceration, which is full thickness, GERD, often scattered eos, usually less than 15 high power field, infections, think Candida, HSV, CMV, medications, your bisphosphonates, doxycycline, for instance, iron, eosinophilic esophagitis, GERD, EOE, typically greater than 20 EOs per high power field. You'll have laminar propria fibrosis, trachealization, and tug sign on endoscopy. Allergies, systemic autoimmune disorders, medication reaction. Parakeratosis, you'll have your nuclei in the superficial squamous epithelium layer. GERD, Candida esophagitis, esophagitis dessicans superficialis. You'll have ghost nuclei with preserved basal nuclei, not that much inflammation. You can see clumps of bacteria. Epidermoid metaplasia, keratinization with a granular layer, possible increased risk of squamous cell carcinoma. Lymphocytic pattern in the esophagus, GERD, lichen planus, graft-versus-host disease, Crohn's disease, contact mucositis, CVID, celiac disease, dysmotility. Stomach, you can get your oxyntic mucosa, which is predominant 90% of the stomach. You'll have these pink parietal cells and the purple chief cells. Antral mucosa in the distal antrum and cardia, where H. pylori likes to live. Reactive chemical gastritis, you get this corkscrewing, loss of foveolar mucin, lamina muscularis mucosae splaying, edema, minimal inflammation, can be due to chemical irritation. Portal hypertensive gastropathy in people with portal hypertension, you get dilated capillaries in the lamina propria. GAVE, all the above findings with fibrin thrombi. Acute gastritis, H. pylori, H. heilmannii, MEDS, focally enhanced gastritis, CMV. Chronic gastritis in the lamina propria, H. pylori, especially when there's germinal centers. AMAG, get your gastrin stained to see if the antralized mucosa if it's positive, then it's in the antrum. If the gastrin stain is negative, then it's Oxyntic, but it's antralized, and that increases your suspicion for AMAG. Get your chromogranin or neuroendocrine markers, and you'll see the ECL cell hyperplasia from the excess gastrin stimulation. MEDS, CVID, celiacs. Lymphocytic gastritis, intraepithelial lymphocytes, as you can see here. H. pylori, celiacs, MEDS, HIV, Crohn's, CVID, lymphocytic colitis, lymphoma, collagenous gastritis. That multi-interstate highway in the subepithelium with intraepithelial lymphocytes. I see this in collagenous colitis, enteritis, celiac disease, MEDS, Helicobacter, other immune-mediated disorders. Eosinophilic gastritis, greater than 30 per high power field. Eosinophilic gastritis, gastroenteritis, Helicobacter, parasites, connective tissue disease, vasculitis, food allergies, MEDS, IBD. Oxyntic gland hyperplasia, hypertrophic parietal cells with snouts. Single is funded gland polyp due to PPI use. Innumerable or dysplastic, think FAP, 5q2122, MUT-YH associated polyposis, Zollinger-Ellison syndrome, think MEN1, a functional neuroendocrine tumor. Foveolar hyperplasia, corkscrew glands, mucin depletion, edema, hyperplastic polyp for single one, innumerable Menicheres, P10 syndrome like your Caldens, Cronkite Candida, juvenile polyposis, Peutz-Jeghers. The latter three also have juvenile polyps in the small bowel or colon. Small bowel, villi, blunted celiacs, goblet cells gone, autoimmune enteropathy, intraepithelial lymphocytes, early celiacs, plasma cells gone, CVID, critters, giardia, vessels okay, if not, amyloid vasculitis, endocrine cells gone, endocrine dysgenesis, acute duodenitis, neutrophils in duodenum epithelium, peptic duodenitis is your differential, and look for that foveolar hyperplasia, metaplasia. Infection, think about Helicobacter, adenovirus, CMV, viruses, MEDS, NSAIDs, IBD, particularly Crohn's. Acute ileitis, think about MEDS, infection, and IBD. Eosinophilic gastroenteritis, greater than 60 per high power field. Eosinophilic gastroenteritis, parasites, connective tissue diseases, vasculitis, food allergies, MEDS, IBD. Chronic injury includes crypt branching, dropout, pyloric gland metaplasia, as you can see here, with villus blunting and a basal lymphoplasmacytosis that kind of pushes the glands in the mucosa. You can see this in IBD, diaphragm disease, MEDS like mycophenolate, ischemia, radiation, graft-versus-host disease, graft rejection, IPAA findings, ileopouch anal anastomosis, pouchitis, cuphitis. Malabsorption, villus atrophy with increased IELs, gluten-sensitive enteropathy, celiac disease. Check your anti-gliadin, tissue transglutaminase, anti-endomysial serology. Greater than 20 per 100 enterocytes is high. Check the tips of the villi. Other protein sensitivities: cow milk, soy, eggs. Peptic duodenitis, meds, olmesartan, NSAIDs, small bowel bacterial overgrowth, CVID, tropical sprue, autoimmune enteropathy, foamy macrophages, Mycobacterium avium intracellulare, Whipple disease. Both are PAS positive. Only Mycobacterium avium intracellulare is AFB Phyt positive. Dilated lacteal, primary, secondary. Secondary can be due to obstruction, tumor, adhesion, strictures, prior surgery. Colon, test tubes on a rack. Focal active colitis, meds, acute self-limited colitis, bowel preparation artifact, ischemic colitis, IBD. Acute colitis without features of chronicity. Infection, CMV, Salmonella, Shigella, Campylobacter. Check your PCR profile. Medications, NSAIDs, Kayexalate, Sevelamer resins, and ipilimumab. IBD, very recent or partially treated. Chronic active colitis with features of chronicity. IBD, infection, diverticular disease like SCAD, diversion-associated colitis, because cells are happy when they have that fecal stream. They're angry if they don't have the fecal stream. STD proctocolitis, look for the tons of plasma cells. Cord colitis syndrome, meds. Ischemic colitis, ischemia, infection, E. coli 0157H7 and C. difficile, medications. Eosinophilic colitis, greater than 60 per high power field, eosinophilic colitis, parasites, connective tissue disease, vasculitis, food allergies, medication, systemic mastocytosis, IBD. Lymphocytic colitis, increased intraepithelial lymphocytes. Lymphocytic colitis, collagenous colitis, meds, viral infection. Granulomatous colitis, Crohn's, infection, nonspecific mucosal injury, meds, sarcoidosis, cord colitis syndrome, diverticular disease, CVID, chronic granulomatous disease. Apoptotic colitis, graft-versus-host disease, medication effect, especially mycophenolate. Pigments and inorganic material, iron in lamina-propria macrophages, prior mucosal microhemorrhage, coarse crystal surface, iron pill, subtle and uniform deposition, deep glands, iron overload. Resins, Kayexalate, purple, narrow fish scale, Sevelamer, bright pink to rusty yellow with irregular fish pattern. Bile acid sequestrants, does not cause injury, bright pink, orange on H&E. Lifting agent, think O-Rise, Eleview. If you think it's amyloid, then get your Congo Red, will be negative. Cropovidum, coral-shaped, pink center, biologically inert. Microcrystalline cellulose, birefringent, transparent on H&E, biologically inert. Calcium, metastatic is due to high serum calcium, dystrophic, damaged tissue due to injury or idiopathic. Get your von Casa if you're not sure. Yttrium-labeled microspheres, your UFOs of the GI tract. Uniform, dark, opaque, perfect circles, given by IR as internal radiation therapy. Melanosis, deposited lipofuscin, associated with laxative, but can be seen in any disorder with increased epithelial cell turnover. Tattoo, coarse granules and macrophages used to mark lesions endoscopically. Mucophages, very common in the rectum. Mucin-containing macrophages and lamina propria. Pseudolipomatosis, air, empty spaces, irregular in size without a foreign body reaction. Pneumatosis cystoides intestinalis, empty space with a foreign body reaction and happen in vivo, often iatrogenic or infectious cause. Well, again, thank you so much for accompanying me on this journey through Kurt's notes of patterns of GI tract injury. As you can see now that there are overlapping differentials like meds, NSAIDs, or GERD for the esophagus, or IBD or graft-versus-host disease. So I hope you enjoyed this video. Again, happy holidays, and we'll catch you next time on Pathagonia. Bye.